Very nice that you came today, and we're gonna go through ABB and we're gonna count things today. And basically this seminar is aimed on that you understand what is compensation and what is not, or what is a simple ABB change and what is a mixed change. Okay, but before that I will repeat the things. ABB and compensation. This is very important. Basically over here I'm going to tell you some formulas to use and these formulas help you to tell if the ABB change is some kind of only compensation or if there is something suspicious, something else that is going on in the body and it's another disorder, ABB disorder, that is mixed to it. That's why it totally makes you blind again with the idea what was initial and later. Okay, so but before that, partial pressure of oxygen in arteries. What is a normal value? In millimeters of mercury, it's 100. Okay. This is not important for today, but anyways, in veins, and you never, for black gases, never take, or for Astrup, as we use in Europe and in Scandinavia mostly, and he was a Danish doctor, scientist, so we use the term Astrup, and in veins, this is what? 40, okay? But that's not important for Astrup. For Astrup, it's important this, O2 in arteries. That's important. Always take arterial blood, never the other one. Then, partial pressure of oxygen in veins is 40. For CO2, in arteries, is how much? It's 40. And for veins, goes up, of course, because the blood goes through the tissue and it gets rid of CO2. It's higher, 46 millimeters of mercury. These numbers you should know really well. Then another number you should really know and really remember is bicarb in the arterial blood, and that is like a day, 24 millimoles per liter. Okay, and then you should know how to count A gap. And A gap you count, there are different ways, but we use the simplest formula, and for the simplest formula the result is 12. But always before you start counting this, you have to check albumin. Albumin has to be normal. If it is not normal, because this is just a counted value, albumin will wildly change the normal A gap. So be aware if someone has nephrotic syndrome or cirrhosis, okay, so liver problems, then he has decreased albumin, and the real number that A gap should be is not 12. It's going to be different. It's going to be lower. Okay, yeah, okay, good. So anyways, pH, just to remind you, and this is not equal because we would need a constant over there, but forget that. Important thing is you should remember that bicarb is up, okay, and acid, in other words CO2, is down. So this is acid, this is base, and what more, this is metabolic part, and this is respiratory. So in case CO2 goes up, the pH goes down. Okay, in case bicarb goes down, pH goes down, and the other way. Okay, so always remember what is up, what is down, but it's very simple. Just remember bicarb is base, so if I'm losing it, I'm going to get acidic. CO2 is acid, so if I'm gaining it, if it increases, I'm going to get acidic. Okay, yeah, good. So guys, over here is a table which helps you to estimate if it's a pure compensatory response of the compensatory systems, in this case we mean lungs or kidneys, or if it's something mixed to these problems. Okay, and you have formulas over here, and we're going to talk about them. But why there are 6 of them and not only 4? Well, the reason is kidneys. So in case of metabolic problem, there's nothing complicated. We got only 2 possibilities. Either it's metabolic acidosis or it's metabolic alkalosis. Why? Because it's about the compensation system or compensatory system that can tell you more, but not lungs. Because as I told you, lungs have only one speed how to compensate. Either they're on or off, one speed. Okay? So that's why we got only 2 formulas. Okay? We got one for alkalosis, the other one for acidosis. Okay? And in contrast to this, in case of, I'll put a different color, in case of respiratory problems, so this is respiratory, I'll still put this back. This is, this is metabolic problem. So in case of respiratory problems, so either if you're hyperventilating or hyperventilating, you can have two speeds, because the kidneys are able to, in few days, if you're acidic, for example, if you're in respiratory acidosis over here, either you can have it for like that it happened 1 hour ago, that you were suffocating or whatever, or it could be a like chronic problem and that you're having a COPD for months. And the cool thing about kidneys is they are able to, in third or fourth day, if they're, noticing you are acidic, they're able to, they completely change their metabolism, and they generate special channels or whatever, and they make themselves much more powerful in getting rid of acid. Okay, but it takes time. That's why we have 2 speeds. If the kidneys start just now, it's 1 speed, and this speed is slow. If they got more time to react to this acidosis, and it takes more than 4 or 5 days, so it takes weeks, then they are much more powerful in getting rid of acid. That's why you can also, only from the S strip, which you'll take from the blood gases, you can sort of guess, in case it's a respiratory problem, and then you change how well the kidneys are reacting to it, you can tell basically, oh, it happened, you don't know the patient's history, but still from the numbers you can tell, oh, it happened yesterday. Or you can say, oh, this has been going on for months over here. Okay? So that's why we have 2 formulas. So, yeah? So this one and that one. Over here we got for acidosis only 1. Okay? So, and still I'll tell you more. So let's get back to metabolic acidosis. So if it's metabolic acidosis, lungs are able to just compensate it to a certain point, and they have 1 speed. That's why, basically, you take blood gases, pH is low, and then, because it's metabolic, then you're checking this, of course, you know already, because it's metabolic. And that means, over here, the formula means, delta means the change. So my example here will be, in case, for example, normally bicarb is 24, but now I will take blood gases and bicarb is going to be 20. So the difference, delta, is 4, yeah? 24 minus 20. So that's delta. Delta is 4 for the bicarb, because it's metabolic. So, and this formula says that if the bicarb decreases by 4 from the normal values, and you multiply it by 1.2, so 1.2 times 4, that's 8, that's 4.8, then you should expect, in case there are only lungs that are compensating it, and there is no other ABB disorder going on at the moment, then the lungs should be able to decrease by their activity the CO2 by 4.8. So that means 40, that's the normal value of CO2, minus 4.8 is what? It's 35.2. So in case in this theoretical example, bicarb, you take blood gases, and bicarb is 20, and this one goes to 35.2. And if it fits these numbers, then you know it's just the change of CO2 is just a compensatory reaction of the lungs. Okay? Yep. Yeah. So if you take blood, someone comes to, so in case someone comes to and he's acidic because he maybe has a diabetes, and then you change his, you check his CO2, and with bicarb he's 20, and CO2 is 35.2. This is exactly according to the formula, and you know it's rather only compensatory reaction of the lungs. But if the number is way out, or it's 30 or 60 for the CO2, then you know it's not only compensatory reaction, and you know there is something else going on. Okay? Yeah? Okay, get it? So that's for metabolic acidosis. For alkalosis, it's just the same, but in this case, the CO2 will go up. Okay? So if you're alcoholic, obviously you stop breathing in a way to retain CO2. Okay? But with respiratory changes, it's different, because over here the kidneys have two speeds. So basically you can use these formulas also to tell if it's acute or chronic. So if I come, if someone comes to my office and now I see that he's hypoventilating, so his CO2 is, for example, 60. So I will check the formula. This is much easier. You don't have to multiply anything. You just check it and you say, you see, for every increase of CO2 by 10, if delta is 10 or 20 or 30, but for 10, you add the bicarb should increase by 1. So in case over here this is increased by 20, so the bicarb should increase by 2. So from 24 it should jump to 26. So in case someone comes to me, I know nothing about him, but I'll check just the levels. I'll see that it's respiratory acidosis. And if the numbers pass like this, then now I know it's an acute change. In contrast to this, in case someone comes to me, I'll take his blood acid and he's 60 with CO2. But over here, look at the formula. For every 10 increase, the bicarb increases by not 1, like in this case, but by 3.5. So in our scenario, it's by 2. So 3.5 times 2, which equals 7. So now I would expect that bicarb goes from 24 to 31. So again, if someone comes to me, I take his blood, and he has this and this exactly, I know it's rather a chronic respiratory acidosis, yeah? Okay? With only compensation, pure compensation. In case someone comes to me, I take his blood and I can see he has respiratory acidosis, and he fits one of these numbers, I can say either it's acute or chronic. In case it's not fitting it, it's going to be maybe 40 or maybe 20. It's not according not according one or first or second formula, and I know he's way out, and now I know there's another problem going on. Okay, not only this respiratory cause, there could be metabolic. He can vomit to it. Okay, he can have diarrhea or something, and then he totally is mixing his ABB disorders. An analogy to this is with acute and chronic respiratory alkalosis. Okay, although you're using different formulas, watch out. Okay, over here also you can see. Look at this. In first 2 days, 3 days, kidneys only boost the bicarb by 1. But after they get rebuilt and really start to focus on the acidosis, they are able to increase it by 3.5. Okay, so they're more powerful in fighting the pH change. So in case of the first case, or A case, this is acidosis. So I'm looking for CO2 change or bicarb change that goes with the acidosis. Is CO2, if CO2 is low, is this acidosis? No, that's alkalosis. But is decreased bicarb from 24 to 4 is telling me that it's acidosis? Yeah. So this one goes with the acidosis. So then this should be a compensation. So this looks very much like a metabolic acidosis. And now I will have to use the formula to find out if it's just pure or if there's something else to it. So what I'm going to do is count it. And this is if 24 minus 4, that equals delta for bicarb is 20. So basically what I'm going to do now is I'm going to check how much the bicarb decreased, and I'm going to multiply it by 1.2, and this is what? 402. So this is 24. So delta of the CO2 should be 24. So then I have to 40 minus 24. I have to subtract from 24, from 40, 24. And what I'm getting is what? Is it 16? It is 16. And now I'm going to check it. So this is like prediction. And I'm going to check the reality, and it fits. So I know it's a pure metabolic acidosis. Okay? We're doing B. And over here, look at this. So this is acidosis right away. It's acidosis, okay? And you have to find what goes with the acidosis. Is CO2 or bicarb getting with acidosis? Well, it's the CO2 because there's more of it. So basically, I know it's respiratory acidosis, and now I'm going to check the table. And when I look, I got more formulas over there. So I'm going to start using the first one for acute change. And the formula tells me that for every increase of CO2 by 10, the bicarb should increase by 1. Over here, it's by 20. So the bicarb should increase from 24 to 26, and it just fits the formula, so it's acute. Okay? And it fits, so there's nothing else going on. Okay? So, and if we look at this case over here, pH is high, so that's alkalosis. And then we're finding the one which combines with it, and it's increased bicarb. So that means, and this would be acidosis, so that means it's metabolic alkalosis. And now we have to find out if it fits the formula or not. And what we're going to do is check the formula. And formula over here says with the metabolic alkalosis that the delta of the bicarb, which is over here, how much? It's 10. It's 10. So you should multiply it by 0.7. And that is 7. Okay? And it should be increased from the 40. So 40 plus 7 is 47. Okay? And you see it here? This 47, you check the real number, and it's 47. So this is a pure metabolic alkalosis. Okay? Pure. Good? And what about the next one? So, and the next case is what? So this is alkalosis. And now we have to check if this fits or that. And obviously this fits because it's alkalosis and CO2 is decreased. So that would be respiratory alkalosis. Okay. And because it's respiratory problem, we have to say still if it's acute or chronic. So we're going to check the formula for acute respiratory alkalosis. And over here, as you can see, for every change of every 10th decrease of CO2, the bicarb should decrease by 2. So this is decreased by 20. So the bicarb should be decreased by 4. By 4. And is it fitting? 24 minus 4 equals 20. And look at this, and look at this. Yes. So it's acute respiratory alkalosis. And it's pure respiratory alkalosis, yeah? So, and if we check the case E, it's very simple. 7.4, 40, 24. This is normal values, okay? Nothing to deal with. So we're having case this one. And look at this, it's acidosis. And increased CO2 means acidosis. Well, but over here, this means also acidosis. So you don't have to count anything, you know, it's mixed. So you won't find the compensation, which is there somewhere hidden, but you won't. So it's just a combination of metabolic acidosis plus respiratory acidosis. That's it. Okay. If we check the other case over here, so pH is 7.4, and this is a normal pH, but if you look farther, this is way out, and this is way out. So this just directly tells you if you take someone's pH and it's normal, and there is one of these, either CO2 or bicarb way out, you don't have to count anything. You know there is something serious and more serious disorders coming or going on in the patient. But somehow if you add it together, it makes normal pH. So you don't have to count anything. This is right from start. You see a metabolic or respiratory acidosis, and over here you see metabolic alkalosis. So it's a combination definitely of these two. But there could be some other processes definitely hidden behind this combination of these two, okay? So you don't have to count anything, or you can't actually, because it's normal pH, but the CO2 is way out, and you just know there's something on. So this case, pH is high. That's alkalosis. Now CO2 is low. That looks like respiratory alkalosis. This would be respiratory metabolic acidosis. So it's respiratory alkalosis. And now we have to find out if it's chronic or acute. If you take it for acute, for every 10 which goes down, every CO2 by 10, if it goes, you get 2. So this goes by 20. So 2 times 2 is 4. No, so it's not, should have been 20, so that's not fitting. Then you go for chronic, and this is by 4. So 2 times 4 is 8, okay, so 2 times 4 is 8. And this one is how much? So from 24 minus 8 is 16. So you would expect this should be 16. In this theoretical, mathematical, unreal situation, it's not exact. Maybe they would do a better job if they would put bicarb like 12 or 13, but let's make it, there's a difference only by 1 notch. So what does this tell you? In case this would be just a normal compensation by the lungs, it should be 16, but it's even more a bit. So it tells you somehow that this bicarb got decreased by some other process. So very likely we can say it's a rather chronic respiratory alkalosis, because it's near to this formula, but maybe plus metabolic acidosis, because this one is decreased even more. Okay, yeah, get it? But still there could be some other things going on, and basically we are totally blinded by this. But still, this is the, I hope, if we talk about 2 disorders, this is the only 2 disorders, this would be the explanation, okay? In this case, 58-year-old male with symptomatic chronic emphysema and bronchitis is being referred to pulmonologist. The following ABGs are obtained. And what I want now is you to find out, check the pH, check the bicarb, tell me what type of ABB disorder this is, and if it's pure or not. And maybe also if it's acute or chronic, okay? We check the pH of this person is acidic. We change the bicarb, that would be alcoholic. So this is the one which fits that, so it's respiratory acidosis. And now we have to again say if it's acute or chronic. Because it's bronchitis, so because it's COPD, obviously, I won't waste my time in checking the acute change. I will just directly go for chronic respiratory acidosis. And if I check the formula over here, I see that for every increase of 10 millimeters of mercury, in case of chronic respiratory acidosis, the bicarb should be increased by 3.5. But over here the increase is by 40. Okay, so it's 4 times more. Okay, so 3.5 times 4, how many? 4 times 3 is 12, 14. So I should be expecting that the bicarb should be increased by 14, which means 38. Okay, and is it 38? And is this fitting this? Yes. So I know it's pure respiratory acidosis and a chronic one. Okay, chronic. A 20-year-old college student is seen at the ER. She describes feeling of that she's lightheaded, and she complains of numbness and tingling in her hands and shortness of breath. The patient tells you that her symptoms began shortly after having an argument with her boyfriend. She has no past history of significant illness. She takes no medication. Physical exams, including vital signs, chest and neurologic exams, in brackets, but caustic sign, are normal. So over here, guys, what is caustic signs for? First of all, that's a neurological sign. You don't have to know now, but you will definitely have to know for neurology. Basically, if someone is hyperventilating, which is obviously this case, your calcium levels, ionized calcium levels, will get down. And this is one of the explanations why you are more irritable. The membranes of your muscles and neurons are more irritable. So in a way, the caustic sign means you're taking the neurological hammer and you hit the masseters and they should contract. Okay, but what was our problem? Well, look at that. It's alkalosis. Bicarb is decreased, and CO2 is decreased. Okay, so it means it's a respiratory alkalosis. Okay, and now we have to find if it's acute or chronic. So you use the formula and which one fits to it. So if we look for respiratory alkalosis, the formula for acute means that for every 10 millimeters of decrease of CO2, the bicarb decreases by 2. So over here, this is for 10. And is bicarb decreased by 2? 24 minus 2, it's 22. So very likely this is acute respiratory alkalosis, and it's pure. There is nothing else going on. Okay? So over here we're having another case, and this is a 30-year-old female with a history of insulin-dependent diabetes, developed influenza same days ago. So she has a flu. And she has not been eating and she hasn't been taking her insulin. Today she experienced several episodes of cramps, abdominal pain, and vomiting. Physical exam reveals an acutely ill patient. Respiratory rate is increased at 30 per minute. Temperature is 37.8. Pulse is 112. Blood pressure is 110 over 68 when supine and 100 over 60 when upright. Mucous membranes are somewhat dry, and there is a fruity odor coming out of her mouth. Again, check the values, check the patient's history, and try to tell me what this is. So, we got a 30-year-old female, and there are many things that happens to. First of all, over here, what is so important, please remember this. This you will use all the time. That means measure someone when he's laying down, and he could have a normal pressure, and then when you make him stand up, he could get dizzy and the pressure falls down. This is so crucial. This tells you he is dehydrated. What this tells you, you use this in all cases of dehydration, also in cases of bleeding. Remember, in case someone has an inner bleeding, he can just react as this. So that's why you use this very simple test, and this could save lives. Okay, so this is very important. If someone has a car accident, and I'm talking general now. If someone has a car accident and he's not feeling well, you know, his sympathetic trunk is activated, and this could mask actually real bleeding under it. So you measure them when they're supine and when they stand up, and if the pressure falls down, you know there's a leakage or something. So never send them home, never ever. Okay? So, but by the way, this is a different case. She's dehydrated not by bleeding but by losing water, and she has a diabetes, so she has she had a polyuria definitely, which helped the dehydration. But what you're going to do, here more things. First of all, what you can count out of this, you can count A gap. And what is it? How do you count A gap? Well, again, sodium minus chlorides plus bicarb. And this makes what? So sodium is 146 minus chlorides are 110 plus 110 plus what? Bicarb is 8. So how much is this?
30.
Yeah, I'm sorry. This should be 8. So it's 30. Yeah, very good. So A gap is 30. This is increased A gap. So basically we're having what? Look at that. pH 7.2. That's acidic. This is acidosis. This would be alkalosis. So we're having metabolic acidosis with increased A gap. That's important. So very likely this is really because of buildup of ketones behind it. Also, you can count osmolarity, or we don't have urea over here, but anyways, if you multiply 2 times 148, that's almost 300. Okay, so it's 296 plus 296 plus glucose, which is 15, and you know you can see it's very high. Okay, so it's 300 to 311. Yeah, am I right? Yeah, if it's 15, yeah. Good. So it's she's hyperosmolar, obviously, and if you check the pH, then tell me, what is it? Is it fitting the formula or not? Look at that. So if it's metabolic acidosis, you should multiply it by 1.2. So bicarb is decreased by how much? By 16. Okay, so 16 times 1.2. This is 12. This is 3. This is 6. This is 1, 2, 9, 1. 19.2 is delta. So this is how much the CO2 should change. So 40 minus 9.2 is what? This is 20.8. And what do we have here? We got 21. So basically it almost fits the formula. There's a difference by 0.2. So now we can sort of, be philosophical in a way. But still there's one more thing why I know it should be rather combined than a pure. And look at this over here. Vomiting. So definitely The case basically should tell you don't forget. And typically, if this is diabetes mellitus type 1, and if it's longer and she's dehydrated, there will be more metabolic problems going on. Okay, not only ketones but also lactate. There's ischemia, I suppose, and she's vomiting to it. So this is typically, these patients are complicated, and they have typically, the longer the changes, the more other ABB disorders we'll be joining. Okay. And now over here we're having a 25-year-old man that was admitted for a suicide attempt. He has ingested large amounts of aspirin. Upon admission, he was somnolent. Contact with him was difficult because of impaired consciousness. Pulse was 100 per minute. Breath rate was 30 per minute. Blood pressure was 142/88 millimeters of mercury. Temperature was 36.8 degrees Celsius. And he had a toxic level of salicylate. Look at this. So now I want you to, again, think of the ABB disorder, count it, and then tell me if it's pure or not. We got this 25-year-old man admitted for suicide attempt. So he has lots of salicylates, okay, in himself. So we expect this is acidosis. It fits with it. So we got metabolic acidosis. The formula says for every delta you should multiply it by 1.2. So 18 times 1.2 is 2 times 8 is 16. 2 times 1 is 2. 3. 1 times 8 and 6. This is 1. This is 2. So 21 point, and that's why the CO2 should be decreased by 21. So minus this is what? How much is this? It's 18.4. Yes. But is this 18.4? No. It's lower. So what does it mean? It means that he's not hyperventilating. He's hyperventilating more than he should. It's 14. So he's basically, he should, if this would be a normal compensation of the metabolic acidosis, he should be hyperventilating a bit less than he's actually. And the reason is because if you remember during the lecture, I told you that aspirin causes metabolic acidosis, but also it stimulates the respiratory centers in your brain over here to bit more hyperventilate. So it's a beautiful example and combination of metabolic acidosis and respiratory alkalosis. Okay, good. And over here we're having a very beautiful case about a patient that is dehydrated. Okay, so a 42-year-old patient is admitted to the hospital with dehydration and low blood pressure. And basically, what is important over here is that you don't have blood gases. You only have sodium, you only have potassium, bicarb, and chloride. But thanks to this, you can count A gap. And A gap's going to be increased because you count 165 minus 32 plus 112. And this equals 21. So A gap is increased. So very likely this is metabolic acidosis due to increased A gap. And in case we think of just changes that he didn't ingest any acid or whatever, this has two main most common explanation. Either it's due to increased lactate only, or due to also ketones. Ketones, that would mean that he would have diabetes. And basically now we have to decide if this guy has a diabetes or not. And we don't know the glycemia, but there's one hint you should understand from today, and that is sodium. Because as I told you in the lecture on osmolarity, typically if you count the osmolarity, there's 2 times sodium plus glucose plus urea. You don't have urea over here, you don't have glucose, but you got this. And 2 times 165, that's very high. It's 330. And this is what you wouldn't ever expect in case of increased glycemia. Because if you would have diabetes, you would have really high glycemia. And that's why this would already trigger a ADH release, and which will try to push the osmolarity towards 300 or a bit lower. And in this case, if you have high glycemia, you would expect to having a pseudo hyponatremia. So you would expect having like 120 sodium. Not our case. Okay? Not our case. In our case, sodium is high. That's why we don't expect that glucose is even more increasing the osmolarity. Okay? So in our case, this is rather a problem of increased lactate only. Okay? Because in case I would have diabetes and increased glycemia, then the glycemia itself would cause 330 osmolarity, 340. This would immediately cause the hypothalamus to release ADH, resorb water, and dilute other ions and sodium with it. It's not the case over here. Sodium is not diluted. That's why we rather think of only dehydration in this case and only ischemia. So, thanks for watching, and don't forget to subscribe and ring that bell. And as always, check the description below for supplementary questions and other materials.